Welcome, everyone. Thanks for joining our first of our Nurture Me monthly webinar series. So this series is a continuation of the 2024 Nurture Me Summit and aims to highlight many of the great proposed presentations that we are not able to include in the summit. The series will consist of hour-long virtual sessions and run from February through September, including topics related to both maternal child health and substance-exposed infants. First, before we introduce our presenter, Dr. Prast, just a little housekeeping. So today we're using the Zoom webinar format, which focuses on the presenter. However, you are encouraged to share questions with Dr. Prast to answer in the Q&A section. Dr. Prast will be answering some of the questions throughout, and then there will be some dedicated time at the end of the webinar to answer any remaining questions. If you have any technical questions or would like to add to the conversation, please direct your comments into the general chat section. Near the conclusion of the webinar, Ryan Nealon from AdCare will share an evaluation link for today's presentation. We appreciate you taking a moment to provide your feedback, which helps ensure that we're providing quality content. Also, Ryan will be sure to email your participation certificates within 10 business days. And now it is my pleasure to introduce our presenter, Dr. Brendan Prast. Dr. Prast practices as a family and preventive medicine physician at Maine Health Primary Care in Sanford, Maine, and is appointed as clinical faculty at Maine Health Institute for Research, the Center for Interdisciplinary Population and Health Research. In addition, he is an assistant professor of family medicine for Tufts University School of Medicine. He graduated from the University of Rochester School of Medicine and Dentistry and completed his family medicine residency at Maine Medical Center. He then completed a fellowship in general preventive medicine at Maine Medical Center, as well as a Master of Public Health at the University of New England. His career interests include disease prevention, substance use disorders, immigrant healthcare, and population-based research. He has leadership roles in multiple regional and national organizations, serves on the board of directors of the Maine Academy of Family Physicians, and is the board president of the American Heart Association of Maine. I will turn it over to you, Dr. Prast. Thanks for being here.
Of course. Thanks for the invite, Hannah. So we'll just get those slides pulled up and we'll get started. Looking forward to chatting with you all today. And as you heard, I'll have some intermittent areas where we'll have Q&As, comments, and if there are any questions I'm unable to get to or unable to answer during our time limits today, I'd be happy to follow up after via email or other ways. But let's get started with our chat. So we're going to start off this talking about maternal healthcare disparities and preconception care. As you can see from the title, I feel like we have to do better. And hopefully as we go through this talk, you'll see why that's my argument to start. But I'm sure I'm preaching to the choir here because a lot of folks are most likely in agreement that we need to do better for our populations around Maine and around the country. So we can move to the next slide, please. So as you heard from that bio from Hannah, thank you for that, Hannah. You heard sort of my CV on paper, that you see right here. A few of the other things that I'd like to mention is sort of how did I get into this realm of passion about maternal child health? How did I end up doing primary care, family medicine? This actually started, well over a decade ago when I was in Western Massachusetts, where I'm originally from, in college applying to an academic research program for in between my senior year of college. I remember writing this amazing essay about how I was so interested due to personal history, science history, just my passions in oncology, cancer genomics, all of that. And I expected, to be put in a project like that. So imagine my surprise when I ended up being assigned to work in the Department of OBGYN, working with adolescent mothers in the Department of Family Planning at Bay State Medical Center. So that was a bit of a culture shock for me, but it was something where I had amazing mentors, I had amazing experience, and I realized I had been living in a bubble my whole life, and I didn't realize what was happening in the city just a mile from where I grew up. So I learned just about some of the things that were impacting the communities near me, maternal child health in community near me, and around the country and the world. So all of those steps that you heard of Rochester, of my family medicine residency, of my MPH, all come anchored from that experience which was just eye-opening and so important for me to realize where I can best serve my communities, best serve my patients. And that's really why I'm here today and I've done so much work in this sphere. I have a few current projects that I wanted to highlight, and are sort of just that are anchored in some of the concepts that you're going to hear about later today. So I'm currently the principal investigator of a maternal and child health outcomes project, looking at electronic health records data across Maine, New Hampshire, and Vermont, with collaborators and a team that I formed from Maine Health, University of Vermont, Dartmouth Health, where we're looking at outcomes based on immigration status, language, social determinants of health, which I'll talk about later, but all coming back from the initial experience of how can we improve healthcare for our communities, especially maternal child health. In a couple weeks, I've created a project for sexual and reproductive health education for the University of New England, where I'll be teaching their students, again, anchored in this reproductive health mindset. And I'm also looking at a project with a team out of the University of Vermont, where I'm a collaborator, looking at, climate health assessments across northern New England, because we know that climate health, environmental health, reproductive health are all closely linked, and we're finding more and more of a stronger connection as the years go on. So that's just a little more about me, because I've found over the years, as I give talks, as I have discussions with people, it's very important to get buy-in and explain why I care so other folks, when I'm talking to them, will also care. So I'd like to move to the next slide, please. So what we're going to do today, because we have varying levels of expertise, clinical specialties versus non-clinical versus more research, policy, et cetera, what I want to do is make sure that we, by the end of today, obtain an introductory understanding of three key concepts. I'm going to talk about health equity, reproductive justice, maternal mortality, and then also in detail social drivers, also known as determinants of health, as well as their clinical implications. When I say introductory, I mean, this is sort of a more 101 level, because again, you can teach entire college, grad school seminars on these topics on their own, and people do. So I wanted to make sure we have a good start to this. Then with those as our underlying foundation, we're going to talk about patterns and disparities in maternal mortality across the United States, looking at different regions, and that will lead us to our final topic of an introductory understanding of what preconception care is and how to incorporate this into regular clinical practice across the spectrum of healthcare. We can move to the next slide, please. Just the classic disclosure slide. I have no conflicts of interest here. And then I do have one disclaimer I tell whenever I give this talk, or variations of this, to different folks. This disclaimer is that while I'm talking about maternal health here, that is used in the most commonly used terminology internationally and nationally regarding pregnancy-related morbidity and mortality. I am aware, and I know research is aware too, that not everybody that can become pregnant or suffer issues from pregnancy or postpartum care do identify as maternal. So that's just one disclaimer I always want to mention. Next slide. So to get us started, as I hinted at before, I have three key concepts that I want to start talking about that will underline the rest of this talk, with a deeper dive into maternal mortality after that. So the first concept we have on the next slide is health equity. I'm sure many of us have heard about this in different settings, but one of the things that can sometimes be difficult for people is, what's the difference between equality and equity? Because they both sound good in the end. So I have a diagram here that I like to show people, and I'm sure many of you have seen this before. If you want to just forward the slide a little bit. And this diagram shows on the left what health equality looks like. That's sort of typically what our health system can have in locations, and what places tend to aim for, which is people all get an equal chance, whether it's trying to look over the fence by all getting the same, stance up above, the same soapbox. It doesn't work for everybody. One way you can think of that in a clinical setting is everybody in one, say, urban area that lives the same distance from a hospital. So from an equality perspective, they have an equal barrier to getting to the hospital. But is that true? If we just look at distance, maybe, but we know there's a lot more that goes into that. So this one size fits all, or this one box in the diagram, to keep with that metaphor, Doesn't really work for everybody because one person might not have access to the public transportation the others do. One person may not have the child care they need to get to access the care they need at the health system. So although on paper they're the same distance from the same health institution, they may not be able to access it. So that's what I would like to contrast with equity, which is realizing that not everybody is in the same situation. We have to customize what their needs to their context. So in a health equity framework, it's finding what people need, addressing that to the best of our abilities to make sure that they have the services that they need to be at the same level of the peers around them. So that would be improved communication, finances, et cetera, which I'll talk more about later because that's where the SDOH or social drivers of health really come into play. Next slide, please. So as I mentioned, social drivers of health. Many of us see these still as social determinants of health, and there's been a change in terminology over the past couple years, I would say. The one thing that I want to highlight about that is that they're drivers, not determinants. When we hear determinants, we think it's predetermined. If someone experiences these, they're destined to end up in a poorer health situation, more difficult situation, more barriers to care. But we know that's not the case. They are not fixed. They're not finite. They vary based on the situation. So that's the change in terminology from social determinants to social drivers. But no matter what the terminology we're using right now, I want to anchor the rest of our discussion more on this. So you can see the World Health Organization definition of this. They're the social determinants of health, the material and social environmental conditions where people are born, where they live, they work, they age, they play, they pray, that may affect the health of an individual. So what are they? This little wheel here is from the Healthy People 2030 initiative from the US, but you can see just going around the wheel, we have money, economic stability and how much it impacts healthcare, education, access, and quality. What sort of schooling did they have? Did someone have sex ed in school? Was someone able to graduate, or were there barriers keeping them from that, which then impact their employability in the future, their finances? What's the access to their healthcare like? Have their local health systems closed to their birthing centers, so they have to travel much further to deliver their baby? Is it tough to get to their primary care physician because again, they're on the other side of a city with poor transportation? And that's the next one, neighborhood and built environment. What does the actual structure look like that someone lives in? Is it a house that has mold issues, so their asthma is flaring up? Do they live far from public transportation and not have private transportation? Do they have a area where they can walk when their physicians and their healthcare professionals are talking about them going out and exercising? Or do they live in an unsafe urban area where they might not be able to walk because of high volumes of traffic? And then finally, there's the social and community context. Are these people living in a location where they feel supported? They have friends, colleagues, family around them that can help support them in their health struggles? Or are they isolated, have difficulty getting from one place to the other, getting childcare, having support when they need it? So those are all things that really anchor a lot of my primary care experience, my education as I teach other learners of all levels that. So it's just something I want to make sure we talk a lot about before we go further. We'll move to the next slide. Then the final one of the core concepts I wanted to talk about before maternal mortality is reproductive justice. And this was initially coined, although it's been practiced in many ways, but it was came more to common parlance almost 30 years ago from the Sister Song group, where in the 90s they realized that with a group of conglomeration of different organizations focused on reproductive health and social justice, that reproductive health didn't occur in a vacuum. There are intersecting, barriers and oppressions to care that we could not ignore in healthcare. So this approach combines reproductive rights and social justice in one approach. It's the right to bodily autonomy. And when I say that, it's not just the freedom of choice, it's the right to have or not have children. And if someone wants to have or not have children, make sure they have the wages to support themselves and their children or their lifestyle. Adequate prenatal and pregnancy care. I'm not saying, outstanding care. This is adequate. So make sure everybody has access to it. Outstanding if possible. We want to make sure everybody has some sort of care. Want to make sure people are living to the safest lives they can, reducing and preventing domestic violence, improving safety across relationships, across ages, ensuring that there is comprehensive sex education across all areas. And as I talk later about potential barriers and potential models to explain maternal mortality in the United States, this will come up multiple times. And then finally, having adequate access to reproductive health. And this is one thing that I want to highlight if you want to click on the slide. Access is not the same as choice, which is one of the underlying concepts here. While on paper, a state may look like they have great access to reproductive healthcare or healthcare in general across all sectors, it's not the same as being able to actually freely choose and have the ability to do that. So that is just a third of the key concepts I want to talk about. And between those three, with the social determinants and drivers of health, reproductive justice, and just thinking about the health equity concepts, I want to go forward as we talk more about maternal mortality. So next slide, please. So again, maternal mortality is an international issue and also a national issue. So something that can hit very close to home. So I do want to tell people that this is a heavy topic. So if you need to take a break, you need to take a breather as we're talking about very intense things, that is totally fine. Because this impacts people in different ways, whether just seeing something in the media or having a personal experience. All of us have been impacted by maternal mortality in some way. I will also note that I'm only talking about mortality here because morbidity is a whole other concept that could take a whole other lecture and a whole other series longer than we have today. But let's look at just the initial international framework on this next slide. So this is looking at the maternal mortality ratio internationally. This is maternal deaths per 100,000 live births. So what you want to have as a country is you'd want this to be very low. So the dark blue, you can see the United States, Canada, Mexico, they're there. Um, so the darker red is extremely high. More than 1,000 out of 100,000 live births lead to maternal mortality, which is a shockingly high number. So at first glance, it seems like the United States is doing well, comparable to European countries, economic partners as well. However, there are significant disparities across the United States for various reasons that we'll go into and are sort of anchored in those past concepts we addressed. So let's look a little closer at that and talk a little more about what defines maternal mortality. So we'll move to the next slide. So the first thing you may notice is just the marked difference between maternal mortality ratios. And this is the same ratio, amount of maternal deaths per 100,000 live births. But this is across the United States and across multiple other countries. You can see on the bottom, we have Sweden. All the way at the top, we have our US Black population, with the US average less than half of that of the Black population in the United States. So you can see just quickly the immediate difference in the disparities in the maternal mortality ratio in the United States. And this is from 2019 and 2022. Not everything is negative, however. As you can see, the rate has significantly dropped. And there's a downtrend since COVID, the peaks of COVID 2020, 2021, where we had an uptick. Numbers are going down, but those disparities still exist. And that is something that we will address further as we go through this discussion. But as we're talking about maternal mortality, what's important is understanding, what the actual definition is, because it does vary. And I will acknowledge that some of these charts, while they may be from the same time frame, will have different ratios as we look closer. And that's because there are different definitions that are used internationally. In the United States, we primarily use the CDC definition, or death during or within 1 year of pregnancy due to a known pregnancy cause. So that could be a complication due to pregnancy. So that would be, say, someone already had high blood pressure, then they ended up having severe high blood pressure or preeclampsia with severe features that led to seizures and death. Could be an issue that started during pregnancy. So say someone didn't have an issue with their blood pressure before, but that developed in pregnancy and was preeclampsia, or they didn't have diabetes, but they ended up having severely elevated blood sugars during that pregnancy. Or heart issues as well. The list goes on and on. Or aggravation of a non-pregnancy condition by the pregnancy. One example that's often mentioned nowadays would be something, say, mental health, which is definitely closely connected to pregnancy, but that would be initially not quite related per past definitions to pregnancy. So if someone's depression, mental health gets much worse, or substance use disorder gets much worse through the pregnancy due to the stressors associated to that, that would still be related if it led to mortality over that 1 year postpartum. The other terminology that is being used for maternal mortality would be pregnancy-related deaths. That's coming up in other areas. Again, it's a less gendered term, but it's not quite been picked up internationally or in the research terminology. The last definition that I did want to mention, I highlight here, is the World Health Organization definition of maternal mortality. And that is a death from any cause in the 6 weeks after birth. So it is a shorter window, but it is more broad. So any deaths. And some of those numbers we're going to look at these charts are related to the World Health Organization, or looking at that ratio in particular, especially if you're comparing international values. So we'll move to the next slide to talk a little more about this. So I'm a numbers guy. The research I do is looking at patterns, looking at disparities based on the numbers that are there. So I think it's important just to look at different, formats, how this is, presented. What does this look like? What are these disparities like across the United States, across countries, and internationally? So this is a relatively recent publication looking at OECD countries, which are, economically similar to the United States, so higher income overall when we're comparing to other areas. So in theory, having the same economic possibilities as, countrywide. You can see immediately there's a massive difference between, say, countries like Norway with 1.7 per 100,000 deaths, as opposed to the United States where we're up to 21, twice the average of those countries, which is a little under 11. So significant differences right away, and this is just a different way of viewing that last information in a bar instead of a line graph. Let's look at that next diagram that I'll have pop up because again, patterns are so important. This is looking again just at the United States. This is from the PRAMS or Pregnancy Mortality Surveillance System, which the CDC has used to, track maternal and infant health over the years. And why I wanted to show this, although it's a little dated because it goes up to 2018, so this was released in around 2020. It's a 30-year, slightly over 30-year window of pregnancy-related mortality in the United States, and you can see it was just ticking up. Now, some of you may say, okay, looks like pregnancy-related deaths, while out of 100,000 is pretty low. 1987 was only 7. Looking at 2018, it's up to 16, 17 or so on out of 100,000. So the absolute value isn't that high, but again, there's an upward trend. And if you extrapolate from out of 100,000 to the hundreds of millions in the United States, those numbers are significant. And it's something that, although there are naysayers out there that say we don't have as big a problem as being discussed, there clearly is a negative trend there, whether we're looking at the diagram on the left or the diagram on the right, that the patterns are troubling and we need to do better. Let's go to the next slide, please. In case you want to look at more regional differences as well, this is a excellent study that came out in JAMA about a year and a half ago, looking at the maternal mortality ratios by state. So again, like that international maternal mortality document we looked at the start of our maternal mortality focus, this is looking at it by state. So the darker the color, the higher the maternal mortality rate. And they further broke it down by race and ethnicity. So the darker the color, the worse it is. So you can see that there are significant differences based on racial and ethnic groups. You can see, for instance, American Indian, Alaska Native in the North, Midwest, Northwest, significantly higher than the other areas in the country. You can see Black populations higher in other areas, but concentrated in the Southeast. And overall, that bottom right is a total. And again, it seems to be more concentrated in the US South and across certain populations, where that number may have changed over the years and gone down a little bit from the 2020, 2021 peak of the maternal mortality in the United States. But that decrease is not shared equally across all people, all communities in the United States. So patterns are very important. So let's look at the next slide, which is the same study, but they actually compared from 1999 to 2019, so 20-year difference, and measuring the difference in the rates of maternal mortality across those times. You can see here again, the darker the color, the worse things were with a change in the percentage of maternal mortality. In an ideal situation, everything would be white. It would be lighter because things got better as we put more money into healthcare, as people's access improved. Clearly, that's not the case because, again, healthcare impacts people in different ways in the United States. So we can see an increase in pretty much every state with, again, the darker the color, the worse the maternal mortality ratio increased. So in American Indian, Alaska Natives, up 162% in the top states of maternal mortality for those populations. Went up almost 100% in Black populations, Hispanic populations. Pretty much across the board, we can see that maternal mortality increased over the years. And there's many reasons for that. There's some statistical arguments being said that it maybe didn't go up that much, but no matter what, and no matter what resource I have looked at, we know that the rates have gone up across the board. And that's something that we want to address because that across the board that I'm saying is a bit of a misnomer because we know it doesn't go up across the board evenly. There are certain populations that are getting hit harder. And that's what I want to talk about and how we can improve in a simple way, a very complicated problem. Let's move to the next slide. So how is this happening? Now, this is something where I want to take a quick breather because I've been talking at you all for a while about some pretty heady stuff. So if anybody has any comments, any questions, feel free to put the questions and anything in the Q&A. I think Ryan just highlighted that a couple minutes ago. And I'll take a sip of water while we do that. Okay. So I'm not seeing anything pop up right now, but if stuff does come up, I'll make sure to address it later. So Ryan, we can head to the next slide. So when we ask how is this happening, it's important to look a little closer, especially with the group that we have here today across all spectrums of healthcare. It's important to realize where we can intervene and where these issues are occurring. So this chart is from a study looking at across 36 states, the Maternal Mortality Review Committee. It's 36 and not 50 because not every state publishes that data, these data to, for other folks to look at, or they don't report it. But this is still a significant proportion of the United States. Of these maternal mortality cases, you can see that about a fifth of them are during pregnancy, and a 13% day of delivery. So that's about a third total are during pregnancy to day of delivery. 2/3 of those are postpartum up to a year after birth, and that is looking again at the CDC definition that we had talked about. So with that, there's just multiple areas where people are more vulnerable and where we could intervene. So this is just some more food for thought as we go forward in our presentation. So next slide. These are some of the literal causes, again, from PRAMs, slightly more dated data, but it's still relevant because this is similar to the patterns that we're seeing today. These are the relative cause, or these are the primary causes that you can see from, hemorrhage or uncontrolled bleeding that can happen the day of or a little bit after, infection or sepsis, full body infection that can happen after pregnancy. Looking at, amniotic fluid embolism, which is basically a clot or a amount of fluid from the amniotic fluid that causes life-threatening, very often fatal issues, to complications from anesthesia. So a large amount of different things. But what's underlying all of this maternal mortality is something that I've still think is a shocking statistic that has been replicated across multiple different studies in the United States over the past decade. And we can advance the slide. Across all of these, 80% of these pregnancy-related deaths, maternal mortality deaths, are preventable. And that's been studied in different sectors and different populations, and that's what we're seeing. So remember that number, 80%, 4 in 5 deaths are preventable in some way. I'm a family and preventive medicine physician that did a 2-year fellowship in prevention. So that is what I am all about. So if we can identify causes that are contributing to this, we should be able to intervene. But it's easier said than done because there's a lot that goes into this. I talked about those 3 initial concepts of, health equity, SDOH, and, reproductive justice underlying maternal mortality in the United States. It's because it is such an important intersectional problem. We cannot ignore how those impact maternal health and cannot just focus on biologic factors impacting health or the physiology that goes into health, the medications, the surgeries, etc. Next slide, please. This is looking at those disparities that I've mentioned previously across the United States. And these are, again, patterns that have been replicated with different orders of magnitude across the United States in different studies, where these are looking at particular concerns that are contributing to mortality. So mortality related to high blood pressure, pregnancy-induced hypertension in patients and people across the United States. The maternal mortality of Black patients is 10 times higher than that of white patients when we're looking at hypertensive-related deaths. The Hispanic maternal mortality is 8 times higher. We're looking at cardiomyopathy or poor cardiac function. We're looking at almost 5 times higher for Black versus white patients. Hemorrhage or uncontrolled bleeding, as I mentioned, about 5 times increased risk of Black patients higher than white patients. And Hispanic maternal mortality is 3.7, almost 4 times higher from that same concern. And breathing issues, whether it's asthma or blood clots impeding breathing, the Black maternal rate of deaths is again 6 times higher than white populations. In this paper, where I've linked here, they actually broke down different, pregnancy issues, mortality causes, morbidity causes into 17 broad categories total. There are higher rates of those issues in Black patients in the United States for 11 out of 17, which again, that is a massive amount. And that's something that we need to do better with, and something that we're talking about. We're doing more and more research, but we need to do more around the country. And that's what I want to talk about as someone who's been asked to talk about this, someone who's very passionate about it, works with immigrant communities, local communities. Let's talk more. So let's move to the next slide. There's one model that I've found that works very well to explain some of this, especially, in rural areas and urban areas. It works very well. And this was made at this point over 30 years ago at Columbia University, addressing maternal mortality in Africa. Um, I have actually spoken at international research conferences with researchers doing similar projects to mine, where they are also explaining some of their differences they're seeing through the three delays model, but say in rural Nigeria. So very different populations that we're looking at, because I'm looking at Maine-based healthcare systems, while they're looking at rural Nigeria health systems and health providers. But this three delays model, especially when you think in the context of those anchoring discussions that I brought up earlier, is very important. So let's start off with the first delay model, because this is something that the SDOH really can anchor. So there's a delay in decision to seek care, which can lead to poor outcomes down the road. There's a lack of medical knowledge. People may not know they're pregnant because they've already always had irregular periods, didn't know that they could get pregnant. They may not have had sex ed and realized which birth control was effective for their body mass or for certain situations. So there's that lack of medical knowledge, or the lack of awareness of issues that might lead to maternal mortality down the road from unrecognized medical complications or pregnancy. There's a lack of knowledge of the system itself. I have had multiple patients, and this is seen in the research and literature out there, where they may be pregnant, but they don't know what to do. They may go to a pregnancy center that doesn't actually offer pregnancy services, so they have to be referred to another area in another city, which is prohibitive for them to get to. They may not know how to get their insurance coverage, where I have had patients that I delivered when I was, a resident at Maine Medical Center, and they didn't access care until 7, 8 months of pregnancy because they didn't realize they were able to get covered by insurance, by Maine Care. This was only a few years ago in some cases. So they didn't realize they could have insurance and didn't go to care because they didn't understand the system yet. There may be unrecognized illnesses, again, connected to a lack of medical knowledge. Someone may have undiagnosed diabetes, may have a lot of chronic medical conditions that they never were able to see a healthcare professional for, that come to light or get much worse during pregnancy, leading to mortality, like in some of those categories that I showed you all before. And there is underlying this, there's always an inability, unfortunately, to have care, whether that's financial, whether that's cultural, whether it's different barriers. There's unfortunately an inability to have care across the spectrum. And it's something that, as a primary care physician, I know is all too real. And I see in my patients day in, day out when they aren't able to access the care that they need, and seeing how it can impact their outcomes in the future. So that is just one of the three delays model. So there's the delay in the decision to seek care from multiple causes. But I'm hoping you can all see, as I'm going through this, that connection to those initial foundational concepts that I spoke about. So Ryan, let's move to the next delay. There's a delay in an arrival to the facility. Now, this is whether they're in labor, they need to get to a facility for just say prenatal care, imaging, labs, whatever it may be. So barriers to arrival in that hospital could be distance. As I've mentioned, a lot of hospitals across the country are closing their maternal units or their birthing units. I'm working with folks from where we're meeting next week to try to assess this on a research perspective across the United States through the North American Primary Care Research Group, because we formed a collaborative because we're seeing this in all of our states across the United States. There could be a lack of private transportation, as I hinted at before. And on top of that, a lack of public transportation, depending where you're living. If you live in a rural area, your car breaks down, how are you going to get to the hospital if it takes a while for the ambulance to get there? If you don't know you're in labor, you don't know your water broke because you didn't necessarily learn this. That could really add to that delay in arrival to the hospital. And if someone is experiencing life-threatening high blood pressure, life-threatening heart issues, bleeding related to pregnancy, all of that, minutes can mean lives in that case. And if they have that delay, it can be fatal. So the delay in arrival to facility is the second one of these three delays from Thaddeus and Maine. And then finally, we have our third delay, which is delay in adequate care. There's misdiagnosis. Could someone have, a condition that leads to life-threatening hemorrhage from the placenta being in the wrong location, embedded in the uterus, and it wasn't diagnosed due to issues with imaging, lack of visualization on ultrasound? Could they have been misdiagnosed with heart disease when they or missing their heart disease when they're feeling fatigued and just chalking it up to normal pregnancy, which I have seen before. People are getting misdiagnosed. There's delayed or ineffective treatment for some of the reasons I described in that delay in decision or delay in arrival, but they might not be getting the care they need due to financial reasons, a lack of access, all of those things. Could there be inadequate facilities? We know there are disparities across the hospitals and health systems across our country. Is there a frequent turnover in because folks aren't getting paid or they are having extreme burnout? Because everyone in healthcare has seen that since COVID in particular, but it's always been there. Are the facilities just not well suited to the patients we're trying to serve for various reasons, whether transportation wise, socially, culturally? And as part of that, there could be a lack of care coordination that has been seen. I mentioned that insurance example before, or the inability to have care, the lack of system knowledge. Maybe that wasn't coordinated from one institution to the other. I've taken care of patients in my research. I've seen patients that have started their care in one institution or one practice, had to transition to another practice for a higher level of care, had to go to another hospital for a delivery, and then have to go to another hospital for a higher level of care, even than that last one because of multiple issues. You can imagine there could be some issues with communication from one institution to the other, especially if we all don't speak the same language in the electronic health record. We're all on computers, but we don't coordinate as well as we should. And that's where the poor communication comes from as well, which is a major issue, whether signing off patient concerns, which leads to misdiagnosis with that delayed treatment, or it could be that care coordination of just getting someone to the hospital via ambulance, getting them to the right location, to the right specialist if they need one. It's tough to do in a fragmented system like we have across the United States, across many countries. So these three delays and this three delays model from Thaddeus and Main, as I mentioned, this is over 30 years old now, but I argue it is so incredibly relevant no matter where you are looking at maternal health, maternal child health. So it's something that I just hope we all, as we go forward in our different fields and our different levels of expertise in prenatal care and maternal child health, just keep at the back of our head, along with those other foundational concepts I talked about. We'll move to the next slide, please. I don't think this will come as a surprise based on some of the things that I've been showing and some of the charts that I've showed before, but we are actually seeing widening of some of these maternal health disparities. We've noticed that we've seen increase over the past 5 years in death rates in non-Hispanic Black women, American Indian, Alaskan Native populations. Uh, while our counterparts that we are comparing ourselves to in these maternal mortality charts across across nations, while we're looking at similarly higher income countries, swaths of our population are having maternal mortality rates higher, if not no higher than a significant amount of those countries, or many of the ones that are lower income as well. So that is something that is just shocking in a country where we spend the most money per capita on healthcare, but we don't see the outcomes because there are so many other things that go into healthcare. And you can see here, I've touched on all of these, but the quality of the hospital, the delays to care, those three delays I mentioned to prenatal care and pregnancy care, poor preconception care, I want you all to keep at the forefront of your mind because I'm going to talk a little more about that. And if you saw me speak at the PQC for any conference last year in June, this is going to be a bit of a recap from that. But we have, if people have less access to birth control, less medical knowledge about it, they're less prepared for pregnancy, less able to optimize their pregnancy outcomes. And we have poorer postpartum care. So let's look at some system changes that are going on because as I said, we spend the most per capita on healthcare really around the world, but we're not seeing those outcomes. We know, although I'm talking about differences in outcomes based on race and ethnicity, we know now that there are a significant amount of studies looking at the genetics and realizing that it is not a race-based difference. Many of you have already heard this. I apologize for being a broken record because we've heard this, I'm sure, in many different situations. But we know that it is not a biologic change that is causing these significant differences or biologic differences. Another 80% value here, but this time 80% of these differences are shown to be from social drivers of health that are impacting health, whether it's the access, the delays, whatever it may be. So there's a lot of things that are wrong with the system that we need to address. And we're a small but mighty group in Maine. Where our group here, we got over 50 people, but we're just a small amount of the workforce that see patients that are pregnant, see that, and we're a small amount that could impact maternal child health. So I saw some things coming up. Just I had this place as a placeholder. I see a few different things coming up in the chat and the Q&A. So let's see in the chat. I want to take again another quick breather. It's been another about 20 minutes or so. So yeah, septic, just a couple days after going home with a newborn, that's one of those causes that we've seen. So I'm very happy you were close to the hospital. And like I mentioned, that's some folks aren't like that. And Kathy, rural OB unit closed, a delay in, arrival to the hospital because of that distance, had to deliver in the ED because they had twins. I might actually know the doc that delivered them because he talks about that quite frequently when I work with him in the Maine Academy of Family Physicians. But unfortunately, that's probably not the only situation in Maine, which is the most rural state in the country. And yeah, differences in empathy. If we're talking about misdiagnosis, issues in, with communication, with stigma that I've seen. Um, I've had patients that I delivered myself where they didn't come in until 9 months of 9 months of pregnancy because of all of the stigma they'd experienced, where they've been heard their care teams making fun of them, insulting them due to their pain, their chronic issues, or substance use, whatever it may be. But differences in empathy, differences in medical care and procedures, Alexa, is something that I've looked at before as well, and I've helped train some of the community health workers in Maine Health, working with our recent immigrant populations over the past couple of years. And that was one thing that I've talked about a lot with people in different conferences, different education sessions, is difference in cultural, religious beliefs, and just that cultural difference in that delay in communication or barriers. So thank you all for that chat. And that's something too that I see some other chat things coming up that I'll make sure to address in a little while. Hi, Ryan, we can move on to the next slide. So this is just another thing looking outside of the box, or maybe very much in the box if you think like me, but this is something that's different with the system that I think is important to talk about. We can see just the absolute difference in clinicians that do deliveries across different countries that we're often compared with. The dark color on the left side is OBGYNs, and then the lighter color is midwives. You can see the US very much on the bottom there. We're just above Canada, so that's something. It's the first one we're not actually on the bottom in all the charts I've shown you, which is something. But you can see the absolute difference in the ratio of OBGYNs to midwives. So having a much more robust workforce and varied workforce clearly working better in some of these countries because we again have the highest rate of maternal mortality out of all of the countries that are shown here, and with disparities across that. So it's just food for thought that across these countries, we again have the lowest amount of midwives, the lowest amount of clinicians, overall, again, just slightly ahead of Canada, but it's just thinking about that workforce capability and burnout. Then we look on the right side. This is something that's near and dear to my heart. I've done a lot of advocacy around paid family medical leave in Maine. Um, Look at the difference between those, again, similar economic countries. And this is a big difference between Canada and the United States, not so much with the clinicians. Look at, these are not days, these are weeks of federally mandated paid maternity, parental, home care leave. Norway has over a year and a half of time off that people get paid for after having a baby. Look at the second lowest on this chart, 14 weeks for Switzerland of paid leave. And then we are a distant last with zero federally guaranteed. Think about those delays I talked about. Think about reproductive justice. Think about how difficult it is to get to the 2-week, to the 6-week postpartum care visit, to the pediatrics visits, if you have to work within a week or 2 weeks. Now imagine how much easier that would be if you're getting paid to care for your infant, for your family at home for a year and a half. So you have the time you need to care for yourself, get those chronic conditions managed, get protected, from the future mortality that could come if your conditions aren't treated for diabetes, high blood pressure, whatever it may be. So this is just, food for thought and about how we have a lot more forward to, momentum that we're going to need, but we're talking about it now, and that's very important. Let's move to the next slide, please. So what can we do? There's a lot of different angles. As I said, I really appreciate Ryan shared with me the various specialties, locations that everybody's coming from to this webinar today. So what can we do? There's a lot of different things. So I'm going to sort of hone in on a couple different ones, a couple different options coming from my perspective as a preventive medicine physician, a researcher, and a primary care physician. So let's move to the next slide. I'm going to sound like a broken record. I already do. I know I've repeated myself a lot because there are certain messages that I really want to drive home. And this is from the CDC in 2022. 4 in 5 pregnancy-related deaths are preventable. So clearly we have to intervene at multiple areas if we want to intervene in such a wide amount of maternal mortality and pregnancy-related deaths. So how can we do that? I want to think outside the box. And this is where, as a PCP, and I'm going to full disclosure, I no longer do deliveries. I trained to get my numbers for credentialing and all of that, but I realized that I was best suited for more doing a research, more for doing primary care and prevention role. So that's why when I say think outside the box, I'm thinking outside of the typical OBGYN visits, things like that, the family med docs that do the delivery. So let's go to the next slide. Pre-pregnancy counseling is where I think that myself, other clinicians I work with, no one in my practice does OB. We refer across the hall to the OBGYN team for pregnancy care. But pre-pregnancy counseling, I think, is an area where we can really intervene. Again, thinking that 80% of maternal mortality that is preventable. If we can intervene sooner rather than later for these preventable conditions that can lead to death, it's not going to treat everything. All 80% of that are not preventable from pre-pregnancy counseling, but we can get started and chip away at that disparity. There are two ways that I've seen this work, and these are both validated, they're supported. The One Key Question Initiative came out of Oregon. And this is incredibly simple. I'm going to go through the entirety of it right now for you all. Would you like to become pregnant in the next year? That's it. By asking that, you can completely change the direction of pre-pregnancy counseling in the discussion that you have in primary care, in whatever your clinical situation you're in or non-clinical, talking with your clinical colleagues about this. Because if I ask someone, and I do this to all of my patients that can get pregnant or have partners that can get pregnant, if I say, would you like to become pregnant the next year? And I hear a no, then that transitions to, okay, and what are you doing to prevent pregnancy? Let's talk more about that. Are you interested? And then that can lead to a whole contraceptive counseling discussion where eventually at the next visit I place an IUD or later that visit. Or it could be if on the other side they respond with, yes, I would like to become pregnant in the next year. Then I say, okay, are you on folic acid? What other medications are contraindicated in pregnancy? Do we need to get you connected to an endocrinologist for your diabetes before that? Because we're going to have to make some changes. Or I'm someone that specializes in alcohol use disorder where I am and do a lot of work around the state on that and education. Substance use is a huge component of this. You want to be pregnant in the next year? Well, let's figure out how we can cut back on your alcohol use. How can we lead to the best outcomes for you and your pregnancy in the future? So this one key question, I have worked it into my primary care physical and other templates, is an easy, quick way to just get a read of the room. And you don't have to be perfect. You don't have to provide contraceptive care. You don't have to provide, counseling for prenatal care, anything like that. Just asking this question can help direct you to the right resources and help guide that patient. And then the next option, which is a little more souped up version of the one key question, is called PATH, or it's the parenthood/pregnancy attitudes, timing, and how important is pregnancy prevention. It's a bit of a forced acronym, I'll say, but if you move to the next slide, you'll see that this is something that it's what I just mentioned, but it goes into a little more detail for people and it's a little more structure. So do you want to have more children? Yes, no, and you can sort of move them along this diagram, but it provides actual counseling to folks. This is something that you would subscribe to, that you would get some education from this Reproductive Health National Training Center for, but it's something that similarly has been used on, in addition to the one key question. So I think between these two things in primary care, as a PCP, preventive medicine specialist, that is something where I think we can start making even more of a difference, where historically, primary care that, if we don't provide OB, we may not have been as good as. And that is something that I've, seen from the patients that I've taken care of, inherited from other folks, seen in the literature, seen from talking with people across the country and internationally in my research circles, something that we don't always do in primary care for internists, for GPs, wherever you are, but we all can do that. And I hope you have capacity. So let's move to the next slide. So perfect. I just saw more chat coming up. So I want to just, go to the audience. I gave some suggestions, but let's chat about this. But, just for a couple minutes, how could this lead to improved outcomes in maternal mortality in pregnancy care, whatever it may be, child health care, neonatal care. Let me, take a peek at the chat and the Q&A. So Melinda, I see your point too. Yeah, a lot of weight stigma. I had mentioned the stigma about around substance use. I had patients that have stopped coming to the doctor because they were weighed every time, had a very negative experience from what people were saying, or even what was documented in the chart. That's something that I talk about a lot with people, a lot about my patients. And even I've had patients where we have a little card for them. And this is something that I learned at some of those international conferences where hand them the card if they want to be weighed that day. They can hand the card to the person, say yes, please. If they don't want to because of the stigma or experiences they've had, they just say go to the other side and say no, thank you. That's something that I've seen in practice and in research. But yes, the weight stigma in the medical field is something that I have seen firsthand in my patients and I've seen in the research. And Alexa, as a new community health worker, yeah, so wondering if having home care nurse or CHO is helping participants before. I love that idea. And that's something too where you could reach out to a community health worker. And I've done research with community health workers. I've done community education with community health workers. I love community health workers. So thank you for what you do, because I think getting that initial outreach, whether someone's pregnant or not, is so important. So connecting to a community health worker if someone wants to get pregnant, to connect to nutrition, to connect to WIC, in advance, just even having conversations and not official visits can be so vital. And then being proactive with the one key question, Cheryl. Thank you, Melinda. I see your comment. Yeah, when someone else brings it off, yes. If someone brings up the topic first, and that's why I put it in my template to make sure that I ask it, or one of my medical assistants, I have them ask it often to work that into the routine so we can get that conversation started. Oh, Ryan, thank you. I saw the Q&A pop up. Paige, I apologize for not responding yet. Yeah, so Paige, that is a good question. I'm curious if hospitals that are heavily reliant on travel providers, whether employees, see more issues related to coordination of care. So with that, you know, um, that is something where I am curious. And one of the things that I don't have the answer to that right now. I would be surprised if people have to travel further. They're more reliant because of no decreased local workforce. If they bring people from further, people that don't know the area, there's more issues of communication, might be more stigma coming from a different area. There's a lot of things that could contribute to differences with coordination care or poorer outcomes. So I think that's a great question. I'm working with the Maine Academy of Family Physicians. We're actually starting to study this with folks from ACOG. We're at very early studies, but we want to try to figure out if there are more issues with coordination of care for those reasons. Laura, thank you for that. Yeah, so if people drink coffee every day or love raw fish, it would be great to say, we should probably start intervening before you're pregnant, so it's not as hard while you're dealing with pregnancy-related nausea, other concerns, and also trying to cut all of your caffeine or all of your comfort foods out of your diet. So that's exactly why I think asking this proactively can be so important and helpful at decreasing those disparities we're seeing. So with that, that is the end of the slides that I have. We have a few more minutes left for a Q&A. So Ryan, if you feel like closing the slides, my email is right there, though. I know you all have the slides. Feel free to email me if there's anything we weren't able to talk about or you aren't able to get a question in the chat. I'm very happy to answer that or set up a conversation. Open invitation to email me. And yeah, a lot of travel providers, Melinda, only read for a few months. So yeah, it's tough to follow up, for the recommended follow-ups or through a pregnancy if you're only there a few months. So I just want to, feel free to put other questions or comments there. I know people are going to have to trickle off to get to their next meetings, next assignments, whatever they're up to, or just your, very important time. Thank you for sharing your time with me today. I look forward to, chatting more in the future, and I really appreciate the opportunity to be here with you all. So I hope you have a wonderful rest of your day. I'll hang out here for some more questions. And perfect. And Kim just shared the SurveyMonkey link for folks to please fill out.
Thank you so much, Dr. Prast.
Yes.
Oh, Hamda, I see that. Oh, Ryan, sorry, were you going to say something?
Oh, I was just going to add that if you You have a couple of case studies, I believe, you could review if you have a couple minutes.
Yeah.
I'm not sure if that's enough time.
I do, yeah. So we can go to the next one. And I want to address that comment, Hamda, because that's why I'm very interested in, community health workers. I work closely with community health workers. I'm very passionate about community-based research because, both community-based clinical care, co-producing community intervention, so we actually have community voices heard there. I have seen that often where community members do get very frustrated because they don't understand them. One of my favorite experiences of that related to pregnancy is when I was talking about nutrition with one of my recent immigrant patients, who was there with her child, was also, recently pregnant. We were talking about nutrition, and what she said was like, I cannot talk about nutrition anymore because we talked about, having healthy greens, stuff like that. Said, I'm getting my greens, I'm getting my fish, I'm fine. You're not going to get what I talk about. You're a white doctor in Maine. You don't get my African food. It's green mush. And those were her quote. That was her quote, green mush. And at that point, I paused, said, well, what are you talking about? And I realized there was a massive lack of my own knowledge in nutrition for the patients that I was seeing. So working with community health workers around the Portland area and some of the ones that I worked with closely within Maine Health, we actually tried to fill that gap in knowledge by meeting folks from the community and hearing what they're actually eating and where they're buying it. Because she was so upset about just a routine well child check and maternal health visit about what are you eating at home. Just something like that is just another barrier to care, issues with communication, issue with the care coordination. So having that cultural humility is so important. So thank you for bringing that up. Yeah, we still have some folks here and we got a couple minutes. So this is just one example of multiple patients sort of I put together that I saw. And this is just one example of how using that framework that I talked about, we can, address things that can contribute to maternal mortality or just poorer health outcomes, morbidity in the future. We have someone seeking asylum from Cameroon. They just arrived in the greater Portland area, living at a hotel shelter with their 6-month-old, who was born via C-section in Brazil. Doesn't have many resources because seeking asylum doesn't have income, cannot work until goes through the asylum process. Thinks that she is currently pregnant, probably 3 to 4 months along. Most likely got pregnant at some point when traveling from a flight in Ecuador or Brazil to the United States. So in the last minute, that was just, again, food for thought. Think of all the concepts we talked about where we could ask questions that may not regularly be addressed. What is your nutrition like? Any chronic medical concerns? Have you been tested for things before in your pregnancy? How was the last delivery? Was it the C-section medically, necessary due to a severe issue or comorbidity that puts you at a higher risk this pregnancy? So just keeping your mind open to all of the things, all the services someone may need that we don't typically learn about in, say, my medical school training or other locations. But with that, Ryan, I think we'll call it, to a close, make sure people can get to their next meeting. And thank you for running the slides for me today.
Absolutely my pleasure. And thanks again, Dr. Prast. And thank you all. And have a wonderful rest of your afternoon. Take care.